is beautiful if only you can see it. Clear Vision Eye Center helps you do just that. We provide expert service, classy eyewear, and cutting-edge technology, all with a quality customer experience. See better, feel better, and look better. Meet us today at clearvisiongrenada.com or call 444-0055, WhatsApp 409-0055, or follow us on Facebook, Instagram, and Twitter. Clear Vision Eye Center. Let's see life and the world with a clear vision.
Well, good morning to Grenada, Caribbean, Martinique, the rest of the Eastern Caribbean, to you, wherever you are. It's a glorious, really, really glorious Monday morning. And we say thanks for being part of this conversation as we come to you live from our studios up here at Observatory Road. A special program for you, of course, put on by Clear Vision. It's all part of the emphasis to bring healthcare. As you can well imagine, the Rudin administration has made healthcare one of its pillars of growth. And certainly, we at Clear Vision, we understand and appreciate the need. Sometimes you can't come to us, so we are coming to you this morning. I want to say thank you for being part of the conversation, for those of you on radio, television, and of course the other social media platforms. Allow me to introduce my guests this morning. Most, they are no strangers to either, to any one of us. I want to say thanks to Dr. Julian, thanks to Dr. Franklin, and good morning to Dr. Francis Martin. My dear lady, gentlemen, thank you for taking from your precious time and being part of this conversation. And it's all about health, wellness, taking care of our eyes. I will start with a lady, as you can well imagine. Doc, the eyes, the gateway to the world. And very often we just assume that vision, it's a right. We're supposed to be born with it. And we go through our life, sometimes quite carelessly, not realizing it's an aspect of our health that we need to maintain.
Yes, indeed, Mr. Cadore. So vision health is extremely important as one goes through your daily life, and it's something that we take for granted. As we open our eyes every morning, we're grateful for what we see. But it is very important that we take very good care of our eyes, and in doing so, it's very important to get our eyes checked every so often. So when it comes to there is no time that is too early for a patient. So we encourage the little ones to get screened usually before they even enter the preschool period. And there we're able to pick up in terms of early refractive errors, like children that may need glasses in order to be able to see better. And of course that affects the academic outcome. So it's not because the child is not able to learn, it's because there is a visual impairment that is preventing them from seeing. So with that, there's a group of ocular diseases that you usually will check for at that early stage, also including congenital cataracts, children that are born with cataracts, children that are born with glaucoma, right? And for example, eyelid ptosis, which are conditions that would affect the visual pathway, and therefore it needs to be corrected while you have the visual development stage occurring. So we really want to correct these issues very early in life, and therefore having the children checked is the only way to be able to pick up on such things.
It's interesting you start a conversation with children. Very often when we talk about healthcare and issues, inappropriateness of health, we often make reference to the adults. Is this a common trend, or is this something that we've been dealing with all our lives, where you find children at a very early age, they succumb to some of these eye care challenges?
Yes, so it's part of our daily interactions, whereby we see things that children are born with congenital, since in the neonate region. So there are risk factors. For example, if they are premature, there's a ongoing screening program for prematurity of retinopathy, meaning there are retinal conditions that can arise from just a child being premature. So by taking early steps, there are screening programs which have been initiated to pick them up very early. So it's something that it may not often occur, but when it do, you have to be prepared to deal with it. So it's something that is quite important, because as they grow up, these are the future adults. So we need to make sure that they have the best vision possible in life.
Dr. Dr. Julian, one of the things that Dr. Franklin, as an optometrist, Dr. Julian just made reference to refractive errors. Could you expand on that for me? Exactly what are we referring to?
Okay. Like Dr. Julian stated, in checking vision, there is no time limit for it. Even as young as the babies, the vision needs to be checked. I think recently we have a less than a week old patient that they saw in the hospital, and they referred to us to monitor the eye pressure because they suspected what we call congenital glaucoma, and they already started treatment. So, and we work in hand with them, whereby Clear Vision have some special equipment that we can use to check the pressure in those little babies. So refractive error in particular can also be inherit, like you could come from family. So at young age is okay to, sometimes I have parents ask what's the best time to bring their child to check, and at different reasons, like the one we just mentioned here, you see the child was born with already problem in the eyes. Better even if you don't notice any issue, is okay for the child within the first few months. From the time of birth, the doctors that give birth, the pediatric doctors already can see things that are not consistent with normal eye or development, and that could start. But refractive error, there are ways we can dictate it as early as possible. Even though when the child is not yet talking or speaking, there are equipments like retinoscope that you could use to dictate if there is a refractive error in a child. And the early time correction of those refractive errors help these children, especially in their academic pursuits. And we've seen cases whereby a child was seen as not being intelligent or not being smart, and this child was referred to a special teacher, a special school, and a special counselor. At the end, it was actually the teacher, a special teacher they brought for the little child to teach him because he's not following up in school. The teacher gets to think, okay, at a point, he advised the mother, why not we check the eyes? And practically when they come, we realize that this child have very significant refractive error that's been budging. And immediately we take care of that. This child, both his social status and performance in school, even the way they say he play around with the fellow, everything changed. And the development of the child also changed. So we advise at any time, if you notice anything, even if at the age of 3, every child must have already gotten their first eye exam.
At the age of 3?
Yes. So but there are cases, like we said, some of them got their first even from the birth or as soon as they were born, some even within the year, based on what other elements. But in terms of checking, routine check, I think you should check, and then between 3 to 6 years again, and then based on what you see, the doctor can recommend whether it's yearly or annual or routine, whether it's 2 years interval to be, monitoring it. But at the age of 3, I think every child should.
Dr. Martin, Dr. Franklin says, age of 3. You and I know in our work there's a culture, a stigma in Grenada. We are not going to the doctor unless I can't see nothing at all. Right. Let's first talk about that culture and how the challenge it offers in terms of ensuring that healthcare is something that we preserve.
Well,
and eye care specifically, yes.
Yeah, the culture of disregarding health, I think, is what is permeating through here. Not just from an eye standpoint, but for many other disease perspectives, the culture of not going to check is something that we really have to tackle. Thankfully, within our system, there is a well child visit that all children go to from birth until 5 years old. After 5 years, there is no more well child visit anymore. Something has to actually go wrong with you before you actually take the child to the doctor. So at least there is something already present from a system standpoint that we just need to plug in the eye aspect of it, so that child gets an eye examination between the 0 and 5 years when they go to the well child visit. And maybe that's a conversation that Dr. Julian should put forward for us to include this as part of it. But again, overall, the fact that we take so long culturally to check anything, that's the problem that we have, because we do know that there are so many diseases that have eye manifestations. We do know that there are so many medication that has eye complications, and so because we wait so long for culturally to get checked, by the time we get checked, sometimes the eye is already affected because of the disease pattern. So that's a cultural conversation that must take place nationally. Thankfully, over the last years, I am seeing that conversation becoming more and more. The fact that we're here doing this is a tune to the issue that from a whole system standpoint, we're becoming more proactive in terms of checking our health, and certainly eye is going to benefit from that.
Let's branch off to diabetes, and then I'm going to get to Dr. Julian regarding issues of glaucoma and treating with it. Chronic ailments, they literally provide a nesting ground, and often as it relates to healthcare, diabetes being chief among them, hypertension.
Yeah, and those two are they take the lion's share, if you want to put it that way, with regards to the effect it has on the eye. We do know autoimmune diseases do that as well. Lupus and irritable bowel syndrome and those kind of, even psoriasis and rheumatoid arthritis do have eye manifestations as well. But you rightly said, the incidence and the prevalence of hypertension and diabetes is very, very high. As a matter of fact, I would dare say, without having the actual numbers in front of me, I would dare say that between high blood pressure and diabetes, these two, either one or both, and hear what I'm going to say, these two has affected every single household in this country. Every single household. Every household knows some mother, some brother, some aunt, some uncle that has either hypertension or diabetes or both. So if you have a condition where every single household is affected, this is really an epidemic when it comes to health and the issue that we're dealing with. And unfortunately, both of these two guys, hypertension and diabetes, has a very significant implication on eye health. As a matter of fact, one of the things we do with diabetes is to check the kidney functions to make sure that they're not spilling protein in the urine. Do you know that every single diabetic person or hypertensive person that spills protein in the urine, it means that the eye is already damaged?
Right off the bat.
Right off the bat. The back of the eye is already damaged. So it's a matter of playing catch-up game now to give Dr. Julian some serious work to do, and then Dr. Franklin. And so it's a real problem.
It makes both of their jobs easier. Maybe it probably might be a little more in-depth or more lengthy if we can capture those challenges at a much earlier age. Dr. Julian, the issue of glaucoma, it is certainly one of the challenges that you face as an ophthalmologist. First, if you may define it for us, and then contextualize exactly what is it that happens.
Okay, so to continue from what Dr. Martin was saying, just to add a little before I go on. So actually, one of the second questions I would actually ask every patient that comes into the clinic is, do you have high blood pressure or diabetes? As well as, do you have any family history of glaucoma? Because the combination of both hypertension and diabetes is a risk factor for the developing of glaucoma. We see that hand in hand happening. So in terms of definition, so glaucoma is a group of ocular diseases whereby you have a predominant factor which is increased intraocular pressure. And that pressure affects the optic nerve. That is the nerve at the back of the eye, which takes the information to the brain to allow you to see.
Right.
So in other words, there is a problem in terms of your peripheral vision being affected firstly. So glaucoma is a term, the silent theft of sight, because you slowly lose the vision around, your peripheral vision, before you lose your central vision. So in essence, it's sometimes based on the type that you have, it is asymptomatic, and that is where it becomes very dangerous, because in the earlier stages, as you remember I mentioned the children, we have congenital glaucoma, but there are things that we can pick up as a parent. So we notice that the child's eyes is a bit increased in size, so it's a bit bulgy, something we call ophthalmos or bullseye. We can see that the child is very sensitive to the light, so she squints when they're outdoors, or it tears, it runs water. So the parent can pick up, if they're very attentive, these changes happening, or the pediatrician at the early stages will refer the child. Now when it comes to the adult, it's a bit different based on the type of glaucoma. So there exist various types of glaucoma. We call them primary glaucoma, and then we have secondary glaucoma. So in the primary glaucoma, which is those that can be open angle glaucoma, which is the most frequent type that we have on island. When you do the gonioscopic exam, the angle where you have the drainage of the fluid is actually open, yet still the patients have high pressure. And then we have the other kind, which is closed angle glaucoma or narrow anterior chambers. And of course, we have something called acute glaucoma, whereby your patients have a very acute episode, meaning that they were sitting in their house, they went into a dark room, then suddenly they start with intense eye pain, headaches, nausea, vomiting. And when you you went into, for example, your clinic, your eye pressure will be extremely high, sometimes over 40 millimeters of mercury. And we're looking at 10 to 21 being our normal values. So that whole picture is is a very painful experience for the patient. So really and truly, these problems, you want to be able to detect them early and reduce your risk factors. So the other types, which are secondary glaucoma, involves things that you may have or occur to the eye, which gives you a risk factor for developing glaucoma or high pressures. So we're speaking about things like trauma. So you were struck in the eye with a cricket ball, some open injury that damaged your trabecular meshwork or drainage area of the eye, and therefore the pressure goes up, or something that you would have inflammatory diseases on repetition within the eye, for example, uveitis. And these things over time block the angle and therefore cause the pressure to go up in the eyes. So what do we have, like predetermining factors based on genetic makeup? So in my family, I look for that line. So I found out that, for example, if you have a grandparent that were blind, that's an alert. If you had a parent that had glaucoma, you had aunts and uncles that had glaucoma, you must get your eyes checked, because there is a genetic component whereby you have just a structural makeup that is different, and you inherited it from your forefathers, and therefore you can pass it on to your children and grandchildren. So it's very important for these patients to come in and have the eyes screened to look for any changes.
Thank you, Doc. To those of you that's listening and viewing, I want to say thank you for being part of this special conversation, and what is in fact a very special Monday. Thanks to Clear Vision, this conversation comes to all part of our community outreach initiative, where we understand and appreciate that healthcare, eye care, is an integral part to who we are, what we do, and certainly we say thanks for being part of the conversation. If you can't come to us, we are going to come to you, and certainly we want to let you know that we've scheduled a series of outreach exercises for you, and it is quite extensive. Starts in May, and the dates, and we'll provide it to you now, but we continue to make the information available to you. So starting in Granbrough in St. Andrew, the 17th of May, then we move to the 24th of May to Balthazar in St. Andrew, and we then move to the 31st of May in Birchgrove. So that initiative starts in May and goes right down to the end of August. So we start in the big parish. We are coming. Dr. Martin, and Again, for those of you that join us, my team, Dr. Francis Martin, Dr. Julian, and Dr. Franklin. Healthcare, eye care. What do you do? We continue to hear the conversation, early intervention, Dr. Franklin. That could quite easily make your job easier or provide you with a lot much more work on a daily basis. But you wouldn't mind, would you?
I would mind though, because we want, we preach for preventive medicine, preventive eye care. The earlier the better. So dictating or finding out early, and that's what Clear Vision, we invest so much in equipment and to dictate early and diagnose early problems in the eye. Recently, we have invested in OCT, or what we call eye scan, that patients will understand. Is a way to help us dictate some of these problems early. And like Dr. Julian said, glaucoma is an irreversible loss of vision. And when it happens, or when the nerves are already damaged, there may be little on what we could do to get them back. So if we could dictate early and be able to manage it, the person, somebody who have glaucoma can still have vision until the Lord calls them. But and that's why we advise people to try and check your eye often. How often? It varies. Especially in adults, okay, your eye first check will decide, the doctor will decide if you have to come more often, and all this based on factors. There are factors that he will look at, or the doctor will use to determine how often he or she wants you to come in to check your eye. One, if you have, like Dr. Julian said, if you have history of glaucoma. Even at the moment we saw you, maybe you don't have glaucoma, but there's a history in the family. So you are likely to be encouraged to check your eye yearly. And if you have diabetes, and maybe when you came, there is no diabetic retinopathy, is not damaging the back of the eye, the doctor will still want you to be checking your eye every year. If you come, maybe it's just a refractive error or a presbyopia condition, whereby maybe because you reach 40, you will need glasses to read. The doctor may decide, okay, every 2 years, you should come in, let's check your glasses. So it varies, and but the first way to start, the first entry is to start the first, you have to get your eye checked first.
While you're there, though, because you use some terms, and I can well appreciate that we want to be able to educate the public as we go along. So we talk about the refractive errors, which I'm assuming reasonably from I did physics, it has to do with the angle at which lights enter in.
Okay, yeah. So refractive error is like the name sounds, is a inability of the eye, the light to focus for us to see. The normal way for us to see is that light is supposed to come inside the eye. The cornea, the lens, they help the eye to refract and converge at a point at the retina. So this is a process whereby we see clear. When that happens in a proper way, where the cornea was able to bring the light to the retina. So there are people who, because of the shape of their cornea, is not able, the light was not able to focus at it. Sometimes it might also be the size of their eyeball at the back. So we have now some people who can see well at far, but they could see things very close. That's short-sighted, we call myopia. There are other people who, well, they are younger, they could see things far, but they're not seeing things very close. We have hyperopia or hypermetropia. Sometimes we have what we call absolute hyperopia, meaning even though things may be still blurry at far, it's also blurry at near for them. So these people need glasses. There are other things we call astigmatism. It means also is the effect of the cornea, irregular shape. Maybe some part of the cornea looking more smooth than the other side. So when lights come, it doesn't focus. These people will have problems seeing both at far and even also maybe problem at near. So these are the ones we categorize as refractive error. Presbyopia I mentioned is also maybe seen as a refractive, is an eye condition. It's a condition because it comes with age. It's age-related eye problem. As we reach towards 40, the lens in the eye get a little stiff or not being easy to move as it used to. So at that time, the person have problem to focus things at near. When they bring small prints, they will come and they say.
Let me ask you, because you said that, Doc, I smiled. I had I'm not sure if it's fortunate or unfortunate. The other day, I always boast of having 20/20 vision, but that was once upon a time I realized. And I picked up a tin the other day, and I'm trying to read it. And then I'm like, seriously? And I had to call my son, what's in this? And he just picks it up, 1, 2, 3, 4, 5, and I'm like, you could see that? And I'm sitting right in front of it, and I'm like, okay, Joe, the times are catching up with you. Right. And that is very often, Dr. Julian, where the denial, and you too, Dr. Martin, can chime in, because it is very easy when we recognize those challenges, we tell ourselves, nah. What would be your suggestion, Dr. Julian, at that point in time? Or what would be your suggestion to me? Let's keep it personal. Yeah.
Right, so stop giving the eyes too much work to do. So it's not able to focus, as Dr. Franklin will explain to you. We're not able to accommodate to be able to see both near and far as we age. It's a physiological condition whereby we term it presbyopia. So it doesn't matter how you strain or try, it is not going to become clear, the letters. So by putting a lot of strain on the eye, it gives you anything from eye pain, headaches. It's a real torture for the patient at times. So it depends sometimes on the occurrence. Some persons it might happen gradually, slowly over time, 40. Sometimes you meet a patient at 42, 43 that's still not using. They know they need it, but they're still trying to make life as best as they can without it. Yes. So we would advise you at that point in time, once you notice that blurriness and that inability to focus and read, that's the time you should go and get your eyes checked.
I'm just not reading that thing again.
Right. So I had a gentleman tell me that, he said, I know I'm not seeing too well, but I just increase the size of the print on the phone. So instead of dealing, instead of dealing with it, you just try to increase the size of the print. But that is a point in which you would recognize that something is wrong. And hey, this is the time I need to go in and get things checked out. But here at 40, you're actually at risk factors for other ocular disease. So it will be a good time to also have the eye checked completely. We mean both the anterior segment and the posterior segment. So you can pick up early changes. For example, patients that have come in from simple traumas, simple things getting into the eyes, for example, a little piece of metal and these things. Then when they had the eye screen, they just realized at that point in time that they already had glaucoma. Yeah? So the blurriness and the need for the glasses at that point in time is a good opportunity for persons 40 years and over to have the eye checked. And once everything is okay, no problem. Then you only need the glasses to see the small print as we see. But it's a very good time to intervene because the eye gives you symptoms and it tells you that something is not right.
And I think I was given mine last week Tuesday. I was like, sweet Lord, what's happening here? Doc, there is the Sahara dust that we've highlighted, and other impurities in the air. There's also the conversation of medications. Let's talk about both and the impact. We want to keep the conversation as real as can be. And I hear a lot of people that they've been talking about itchy eyes, redness, and all of those sort of stuff. So let's talk about that, the impact of pollution and the impact on the eyes, and what's the course of treatment, and the whole conversation of medication, types of medication, and the impact it can have on your health.
Yeah, Cadore, that is actually true. And you spoke of the denial. You were denying that it's time.
Well, that was just last week, so ease up on me. That was only last week Tuesday.
Because the denial issue also persists in chronic diseases as well.
Right.
That first blood pressure check that you got, that first blood sugar spike that you got, there is a strong denial that maybe this thing is not true, and you allow the damage to go on, even if in the back of your mind you know the pressure is out of control. So that denial aspect is again a national conversation that we need to have on this issue. Environmental conditions and air quality is also something that affects the eye, and Dr. Julian, of course, would be able to chime in on that issue as well. But it has to do with the size of the dust particles. Some of those particles are bigger. They can actually land on cars, and you can see them painting the cars. But there are some that are so small, you can they're respirable, as we call them, so they get into your lungs. These dusts also carry certain things with them. We are aware that from investigating those dusts, we know that there are allergens in them. We know that there are particles in them. As a matter of fact, you may want to laugh at that one, but feces were found in the dust. Animal feces were found in the dust. So, and this is why it is associated with so much skin irritants and irritable situations in the skin, and the eye is very much an example of that. Thankfully, Dr. Julian have very good ways of dealing with this. As a matter of fact, in most cases, Dr. Julian doesn't even need to be consulted on that, because a general practitioner can use some eye antihistamines and so on to help them in that regard. The issue of medication, that is a conversation that I've not had a lot, because a lot of people are unaware that medications can actually interfere with your ability to see and your eyes and so on. We're very much aware. The studies have shown that long-term use of some of those pain medicines, anti-inflammatory pain medicines, has been known to have eye implications. And there's another very common autoimmune medication that we use. It's called hydroxychloroquine. Well, this one, usually the doctor would say to the patient they need to go get their eyes checked. And I can say this because I have had personal experiences of my patients who were on it and were advised to go get their eyes checked because of the what can happen. We also know things like antidepressants does have an effect. Even some of those common antibiotics, that those sulfur-based antibiotics, can affect. And then another group of antibiotics called fluoroquinolones. These are the ciprofloxacins and that kind of things. These medicines has been known, and studies have shown that they can have effect on the eyes as well. Another common one that is used is tetracycline. Those are common medication, and most doctors are aware of this. It is not very, very common, but it's very good to know that that's happening. So the point here is, if you as a patient have visited a doctor and you've given some medicines, and a few days later you find that there is a problem with your vision, then you need to revisit the doctor, because it might be just adjusting the dose of the medicines, or if the doctor may be able to see something else. As a matter of fact, if there are any doctors listening to this program, it's a great entry point to tell them, go get the eyes checked.
Why can't I just go to Google? Dr. Google is always there.
Yeah.
And I'm introducing the Google element, because it seems to become, he's become more trustworthy than the family doctor. If you have one, you know everything. I notice something's not right, and I'm just going to go Google it. And you say, well, okay, it's supposed to have some side effects. Where do you draw the line?
It's a tough one, because generally I encourage people to go to Google. Generally I do. Because what happens when they go to Google, it makes my job easier, because they already come in with questions to me. They're always saying, you know, so I can point exactly and deal with exactly what they need to know because of that education gap that's in there. So I encourage people to go to Google on two occasions. One, after I've made a diagnosis for you and I put you on something new that you never knew before, when you go home, go to Google and get checked.
Do I get a reduced price when I come to the office?
Well, in some cases you don't have to pay, because we can use WhatsApp to communicate.
I like the sound of that.
Yeah.
Dr. Julian. And again, good morning to those of you that's at home. Wherever you're following us, we say thanks for being part of the conversation. This conversation comes to you all part of, thanks to the team at Clear Vision. And this is part of an ongoing, certainly we've had these outreach missions before, but we strengthening it, understanding and realizing the need. It isn't always possible you can come to us, so we can come to you. And it's on that note I want to tell you, while it's early, that the team at Clear Vision will be doing some community outreach screening that starts in May, which is next month, literally. Starting from the 17th. On the 17th, we'll be inside of Grand Bras in St. Andrew. On the 24th, Balthazar in St. Andrew. And the 31st of May, inside of Birch Grove. We'll then move to Rose to St. Patrick. We'll move to St. Mark, St. David, St. George. And I'm almost certain that at some point, Carriacou is going to become part of the conversation. But let's leave that there for now. And my team in studio, for those of you that's probably wondering, Dr. Martin, Dr. Julian, and Dr. Franklin. Hypertension, diabetes, again, two culprits that invade our lives and they become monsters if left unchecked, Dr. Julian.
Yes, so these are two very important chronic non-communicable diseases, and it's very important that we address them first at the primary healthcare level, and Dr. Martin knows all about it. So just to give you a little statistic, so from the Centers of Disease Control, it is estimated that around 89 or 86 million, between 86 and 89 million adults 20 years and over are diagnosed with hypertension in the US. So we're talking about very, very high numbers. We're looking at a prevalence rate of about 34 to 45% recently. So latest data would show to you that when you compare the stage at which the hypertension occurs, it actually reflects the effect upon the eye. So most patients that are at stage 1 hypertensive, they already have changes happening at the level of the retina. So not only the eyes, we're talking vascular diseases, the end capillary damage, renal changes, and of course the eye does not escape that. So we have a lot of very small vessels, microvascular changes happening due to the elevated pressure. And coupled with that, you have atherosclerotic changes or hardening of the arteries. So imagine blood is trying to pass through something that is already narrowed, hardened. It causes turbulence on the flow. And during the flow rate changes, and that can even cause the formation of clots or thrombosis. So a lot of the patients that are hypertensive, it starts off with early vascular changes in the arteries. So first we see that the arteries are a bit narrow. So you see narrowing and hardening of the retinal arteries. We also see that there are distension of the venous vessels. You may have pathological crosses. When a vein crosses over the artery, it cuts off the circulation, causing ischemic changes. It gives us exudates, hemorrhages, edema within the areas of the optic disc, and it can give you in very large areas of ischemia, which we call cotton wool spots, which is ischemic changes at the level of the ganglion cell layer. So it looks like cotton wool changes or exudates.
But
so
Doc, while you're there, for the folks that's at home and wondering, what is she talking about? Hypertension, diabetes is going to give you more in your life than you've ever catered for. Is that a nice way to summarize it?
Exactly.
Yes. Okay. So can I see Tanti home and she's probably wondering, what is Doc talking about?
Yes. So the high blood pressure, it causes a range of problems. So it's very early. For example, a person that already have grade 1 and grade 2 hypertensive retinopathy, they have a 1.35-fold of having stroke. So it's a risk factor to develop stroke and heart attacks. And so when you can even predict based on how your vessels look in the retina, in the back of the eye, your chances of having a stroke within 5 years or 10 years down the line. So that's why it's the importance of hypertension and retinopathy. So it's very important. Screening the eye protects you, give you that mechanism to alert your primary physician, hey, that patient needs to be placed on medication, and tighter control so that you reduce that risk factor for stroke. When it comes to the diabetes, as Dr. Martin would have mentioned, all those changes, It starts from the front of the eye, but most concerning to us, I mean, diabetes for me is like my #1 point of concern along with glaucoma and ocular traumas, because we see so many patients with diabetes come to us in very late stages, whereby we call advanced diabetic eye disease in the older days, but we actually classify them now as proliferative diabetic retinopathy. So we see that you have bleeding, we have deposits of fats, we have blockage of vessels, and therefore even bands being formed in the retina, which we call fibrovascular membranes, that pulls on the retina and cause retinal detachment. Now, retinal detachment is a cause for irreversible vision loss. Right? So we're talking about things that are sight-threatening. Diabetes leads to blindness. That's very clear. So it's very important to intervene in the early phases whereby it doesn't get to that proliferative state, and therefore you give the patient a better outcome.
Diabetes, hypertension, glaucoma, it isn't a death, it isn't a life-ending sentence. Is that a reasonable conclusion?
Yes. So with modern advances, there are treatment options. So the treatment option for glaucoma, we have both medical treatments, which are eye drops. That's your first line.
Right.
Now, if a patient is not controlled on one eye drop, as we all know, most of the population, you're familiar with being on timolol or dorzolamide or Cosop. Now, if a patient does not improve, then you have an increase in the group of medication. So you use a different group added to get a better optimum control of your pressure in the eye.
Let me ask you though, while we at it, my grandmother is using it. She's diabetic. She went by all three. She visited all 3 doctors, so it's confirmed.
Right.
20 years later, she's still on the drops. Is anything wrong with me just taking some of the drops? And
of course, because your grandmother is your grandmother, and what your grandmother has is not the same thing that you have. Your type of glaucoma may be different.
Right.
The stage at which your glaucoma is different, and your eye is different. So it is not safe to be just medicating yourself just based on what your grandmother take. And it also involves following up. So let's say you're using your granny's medication and you use it for about a month or 2, but you have no idea if your pressure is okay or if it's not.
Right.
So you need to go in and have it checked. So we do a check and balance whereby I'm on that medication, but I need to check to have the pressure redone. So the pressure gives you a control. So is it okay with that treatment? Is the pressure better? Is it the same? Do you need to add? Do you need to remove? So it's very important, that balance. And glaucoma patients, we actually see them every 3 to 4 months to keep a tight control on changes in the optic nerve, ensure that the patients both have pachymetry, the OCT scan, which is brilliant for picking up early stage glaucoma and staging in the later rounds.
And that frequency of visit is standard, and it's not you deciding.
No, it is standard.
Let me see how quickly I can.
That's best international guidelines.
And
so sometimes you would see a patient, oh, you have to go by the eye. But if I'm using medication, it's okay.
Yeah.
No. You have to check it because you need to know if the medication is working. Is it advancing? Is it stable? Has it stayed dormant? So you need to monitor. And the only way to monitor is to look at the nerve, do your follow-up OCT exams to ensure that everything is going, and give yourself a best chance so that you can live with the glaucoma as long as God gives you sight. And with the diabetes, you can pick up early and do laser therapy. You can do intravitreal injections in the eye to reduce some of the edema and leaking of the vessels that cause the bleeding and the exudation and so on. And of course, with the hypertension, treating your underlying condition. So a wonderful point is that in Grenada, we have advanced. So we're now in the phase of doing vitreoretinal surgeries right here in the country, something that was not possible before. So by intervening, normally the patient would have to travel overseas to get a vitreoretinal surgery, repair retinal detachment, repair macular hole, do endolaser. So these things are being done within the country and gives the patient a better chance.
And I think if you're trying to home and you're trying to think of a reason why you would want to avoid any of those surgeries, you could consider the economic implication that is going to have.
Yeah,
One, if you lose your eyesight. Two, the mere fact, had I gone visited a doctor 2 years earlier, 3 years earlier, had I decided, you know what, let me go to Dr. Franklin so he can talk to me about some of the checks that can be done. And if so, have you seen any change in trends in terms of some of the checks that what was required, let's say 20, 30 years ago, and what's becoming, or what's given now as we in 2024?
Okay, if I get your question, you mean changes in trends? Okay. Well, from my experience, so far, before we noticed that, especially the women in Grenada are the ones who check their eyes more often, but the trend have really, for the past few years now, like 4 to 5 years ago, are coming. So the trend have changed. We're beginning in Clear Vision to see more men come check their eyes. So which is very encouraging, because I remember the first time I had come to the studio here. I think that was one of the observations I made. That was years back, but that trend seemed to slowly change. So we're seeing more men, coming and get their eyes checked, sometimes even without having symptoms. So that is an improvement. But and at the same time, we also noticed that there are cases of glaucoma I wouldn't know if it's because people are checking more now these days that we see more cases of glaucoma, or is it because it's a prevalence? So, but that's what some of the trends that we see, changes that we see going on over the years. So this time we noticed that a lot of people are being diagnosed of glaucoma, probably more emphasis and knowledge, and the idea that people are coming out to check, unlike before. Maybe that's why we're getting that trend. But it's also encouraging, because all we preach and advise is that people should try and check their eyes, because most of these things can be prevented, or especially at some early treatment or early diagnosis can lead to some of them preserving vision. So you don't have to see a lot of blind people who, some of them, when patient comes,
or shall we say visually challenged?
Yeah, visually challenged. So when you ask the question about family history, you realize that majority don't know about their family history. Right. Some people will give maybe based on their mother or their grandfather or their grandmother, but you don't get much history about their grandfather or their father's side. So we also encourage them to ask, because when you ask family history, it's not just about your mom and maybe your grandmother. So we also want to know about your father and grandfather, ocular history.
I'm seeing some serious conversation having to take place, given in the context, Dr. Martin, where we grew up in the traditional family. It was the extended nuclear family. Many households now are more single-parent families that can't tell you the last time they saw daddy, or even know much of daddy, much as to know his history, because he's not checking anything at all, which is a separate conversation. We spoke about a lot of these conditions, which comes down now, narrows itself down to the issue of lifestyle changes.
Yeah, like
Dr. Martin.
Like with everything, chronic disease, lifestyle changes is paramount to everything. But not just lifestyle changes. Sometimes systemic changes can take place as well. And I always have to remind myself that I am in private practice, but because I have a public health specialty, I do always take the public health, put on the public health hat from time to time. And there's a joke that I give when I go around to do public lectures. I always make that comical joke in my lecture, and that is, I say, our health systems is structured in such a way that we send people away to specialize in a particular area, And when they return, we put them in the hospital to wait for people to come to them. I wonder if you get me.
Expand on that so we get it home.
Dr. Julian, for example, went away to study to become an ophthalmologist, yeah? She returns to Grenada, but she is placed in the hospital to wait for the patient with the eye sickness to come to her.
When in fact it should be the reverse.
Opposite way around. And that is primary health care. The amount of information she had shared here today is, I mean, really, really valuable information. What if our grandparents or uncles in the country is able to hear the same thing, right? Because our doctors may not be as specialized as she is to give the amount of information that they can give as she can. So health systems around the world have to find this way of meshing what you need at the secondary level, but understanding more importantly why you should do the upstream determinants of health and stop things from an upstream standpoint. So maybe the system can be structured in such a way that Dr. Julian gets a chance once a week or once a month to go to Timbuktu and sit and speak with the people in Timbuktu about eye health rather than focusing all her energy at the hospital levels. So this is my old little public health pit that I like to do. But the other thing is, those of you who know me very well would understand that preventative care is what I focus on a lot more. And we know that there are things that can help people to prevent themselves from losing their sight. Behavioral. And from that behavioral, I mean nutritional. Because there are some things you can do. We're very much aware that free radicals or damages our bodies in a lot of ways. So overall, antioxidants are what is needed to promote your eye health. And in particular, we know of two foods that are extremely good for this, and those are the lutein-containing foods and the zeaxanthin-containing foods. Don't worry about those big words. I'll break it down just now.
I know you will.
The lutein foods and the zeaxanthin foods. And to put it simple, it's your dark green leafy vegetables. You cannot overstate this, and not just for the eyesight, but also for your diabetes and hypertension. We're fully aware that the foods under the ground are the best, absolute best, and the food that are touching the ground is second best. So those that are touching the ground is like cabbages, lettuce, cucumbers. They're touching the ground. And as you come a little higher up, absolute good foods, your peas tree and your corn, those are absolute foods that we actually call them eye-friendly foods. Eye-friendly foods. Those are touching the ground, which are your green leafy vegetables, and those that are little about your height, which are the corn and the peas. And as you get higher up, it gets a little bit more complicated. But people focus on that kind of thing to prevent yourself from getting eye disease. It's not just only eye disease, but it does protect you from the chronic disease as well, which, by the way, can also lead to the eye disease. So they're all bundled in one. Behavioral, and it's behavioral, but nutritional is also a big part of it.
So you'd hear the argument, and I know it's out there, well, Doc, I eat all of the stuff, but it then lends to the question, how they are prepared. We've gotten into the culture where everything has to go into a pot. We got to cook the living daylight out of it, and then we consume it. Are you one that would advocate the need for the consumption of more raw, these vegetables in a more natural state?
Simple statement, the crunchier the better. Simple. The crunchier the better. Leave that right there.
Dr. Julian, I make sure you love what you're hearing?
Yes. Because also, just to chime in, the beta carotides, like what we know as the bright yellow colors. So we want the yellow peppers, we want some of the carrots and the pumpkin, which is also important for eye health. So we actually have eye supplements in terms of food is the best that you put in. And if you're not able to get it as you should, then based on the degenerative macular conditions that you have, we also recommend that they're contained within the same zeaxanthin, lutein in things like ICAP and Ocuvite and so on. But basically a healthy diet is extremely important. Fresh fruits, vegetables, vegetables, and of course, if it is in the raw state, it doesn't have more access to the nutrients. So vegan diets, for example, emphasizes a lot of these things, and studies have shown it's wonderful to be able to release a lot of the nutrients that the body is needed. In terms of prevention, I also want to add the fact that how we treat our eyes in terms of our task that we do daily, especially the men, we're asking for the protection of the eyes. For example, you're a carpenter, you use a metal grinder. We're seeing a wide variety of ocular traumas on a daily basis. So it's very important that we use protective eyewear when you're just nailing or you're hammering, because that time, that moment that you just remove the goggles, that's exactly when a piece of metal enters the eye. So you want to reduce the trauma and the damage caused, and these are all preventable. Example, when you're doing the cutting of the grass, the weed eaters, they come with a shield. Leave the shield on, it's for your own protection, right? So as Dr. Mates, they take the shield off to make the work a little easier. But if you don't wear proper goggles that are fitting right around, a little piece of metal goes in and you end up having to have it removed.
And the concern is not just limited to the user, it is also extends to passerbys.
Exactly.
I mean, and suddenly these individuals, they seem quite detached from what's happening around them.
Yeah.
So an ongoing vehicle, you actually have to stop the weed eater to allow passage of the vehicle, because passengers have been struck on many occasions by pieces of stone, debris from the weed eater, causing significant ocular damage. Things that are irreversible and things that are preventable. So ocular traumas is a big cry to have greater protection, and even at the level of the job site, ensure that you as the supervisor of the job site provide protection.
I didn't hear you say that again. I want to make sure.
So I want to emphasize the fact that you take it seriously.
Right.
You're in a construction company. Please ensure that your workers have ocular protection, because they come to us all hours of the day, right? So cement went into the eyes, a chemical spilled went into the eyes. It can be simple as, we had a gentleman once, you were just offloading some degreaser, that is what you use for the kitchen cleaners, but one bottle fell, cap ruptured, and it spilled into his eyes. He went immediately and he irrigated the eyes. He washed it out, because that's the first thing you want to do, remove any of the substance. And because of the nature of it being a hydroxide base, it had sodium hydroxide, which is an alkaline substance, and it went and damaged the cornea. And by the time he got there, within an hour of seeking medical advice, that cornea already turned totally white, opaque. So he lost his cornea simply by not protecting his eye. So then you have to go through an extensive and expensive process of corneal transplant surgery.
Which in fact could have been avoided.
Which could have been avoided.
While we're on the issue of avoidance, and that seems to be central to the conversation of general health, preventative, right? Let's talk about, we're in a digital era, and we have the conversation of length of time, device time, how much hours one should spend in front of the computer, at work, at home, the kids, the devices. That has become an explosive conversation. Can you add to that for me, and how that digital arena that exists with it, when that now exists, whether or not it has added or reduced or lessened on occasions of our challenges, I mean, with
visual-wise, yes. So it's important with the digital era, it's important that we move along with progress, but also we have to take the certain steps towards it. For example, some studies would show that it's best that you do not expose your child before the age of 2 to screen time. That is tablet as well as phone, right? Because the little ones, you have to be very vigilant with them. They tend to put things very up close. They have no idea that they require certain spacing, and if they're left unsupervised with that complete a process of bringing everything up close, it induces something called myopia, right? So the myopia has been studied, and it shows it ranges from minus 1.25 all the way up to minus 3 in terms of changes that having these devices causes structural changes of the eye, changes, and as Dr. Franklin mentioned, induces refractive errors. So it's very important that they use it at the correct distance, introduce it at the correct timing, and of course take the breaks. So you use it, but you need to take at least a 30-minute break, leave it, go outside, do another activity, remove strain and glare on the eyes. And if you use the computer very regularly, for example, studies, you are using a lot of at work, you need to ensure that you have a screen protector, something that also has a blue light filter to reduce glare and therefore a lot of strain on the eyes. So there are spectacles that can be used, glasses, that you can use also to reduce the glare and the blue light filters, which is very important for your health. So I remember I had a patient that the patient always had keratitis. That is inflammation on the cornea, staining every time. And when you got to the root of the matter, it was a lot of exposure of screen time at work, coupled with the fact that they have an AC unit overhead. So these were just too much aggravating factors for the eye. So it's very important that you try to reduce on the exposure with these digital devices and also ensure that you have the proper protection mechanisms in place.
Dr. Martin, stress. We live with it. It has become part of who we are. And the challenge is, hopefully, our ability to manage and cope with it. What's the impact that it has on our health in general and the eyes?
Well, as it turns out, the body has been created in preparation for all the onslaughts that we're going to give it over our lifetime. And so our brain produces two very important chemicals that helps the body to navigate stress. One of them is called cortisol, and the nickname for cortisol is actually called the stress hormone. In other words, if you Google stress hormone, cortisol is going to come up. And if you Google cortisol, stress hormone is going to come up because they're one and the same. And then the body also produces something else called catecholamines, which helps it to deal with whatever your body is going to be stressed out about or dealing with about. It turns out that cortisol has some very significant impact on the human. It directly brings up your blood pressure. It directly brings up your blood sugar. It directly brings up your blood pressure and your cholesterol, all of them. It elevates them very significant in your body. And of course, the catecholamines secretes adrenaline, which makes the body feel as though it needs to fight some kind of things. And those have direct implication on the function of the eye and what the eye has to do. So the eye is actually put under pressure because of the stresses that we're going through. And so having to deal with the stress issue is not only going to help you to overcome, but protects your eye in very much many ways. And even if you have a predisposition to have high blood pressure, diabetes, and cholesterol, just becoming stressful, dealing with a stressful situation can actually convert you right over to becoming chronic diseases if you're not able to manage the stress very well. And this stress we're talking about, it's a whole gamut of it, from depression to anxiety disorders or bipolar personality disorders. These are all kinds of bodily stress that can lead to eye implications and chronic diseases.
I realize I'm having challenges with my eyes, Dr. Franklin, and I'm thinking, you know what? That money I'm going to spend, I'm just going to go to the pharmacy and I'm just going to pick up one of those fancy eyewear for $20, $30. They say that's for reading. I put it on the first time. It seems to work. I'm good to go. Is that a culture? Is that a practice that you would encourage? If so, if yes, no?
No, okay. My answer is no. I want to encourage that, like we've been emphasizing, getting your eye checked first is the first thing to do. And when it comes to presbyopia or refractive error, when maybe you're not seeing something very well, you pick up glasses, we see that as magnifier, which can make you see things bigger. But we have seen with experience that the two eyes sometimes are not the same in terms of their power or prescription or how the anatomy looks. You might have two eyes, the same you having the two eyes, but when you come check, we realize that you can see with this one very far, but you can't see with this one. And you can also be able to read with this one, but you can't be able to read with this one. But it's the same person and it's the same eyes. But so that's why we advise you check first, because I see most patients who come and they say, oh, it's like I've damaged my, I've been using reading glasses for a while, and when you check them, you see that they have what we call like anisometropia, whereby the eye prescription are different. If they are different and you go and pick up the glasses, let's say this one accepted the 2, but the 2 you gave to this one is actually forcing it and stressing the muscles. You end up having headache, even though you are seeing with the other one. So we don't encourage that. We advise people, yeah, there are sometimes when you check it, the person may end up have to just pick up one of the prescription, what we call reading glasses. But the way to know is, the first of all, is to check. You understand? If you don't check, you may not know which one is your prescription. And at a different age, as we get older, prescriptions are different at each point. So somebody who is just 40 years may just need the 1.25, while somebody who is already 50 or 60 may need up to 2.2 or 2.5. So, but you go in and pick it up there, 2.5 will magnify the thing and make it even bigger than the other one. And you may decide that that's the better one because you're seeing the fine prints bigger. And at the end of it, you come back with headaches, and because you're wearing what we call overcorrection and it's forcing the muscles in the eye. Another thing I want to add to what Dr. Julian said about the computer vision and screen time in terms of preventing. Yeah, we advise people to, while you're on the screen, take some break. There are some break time you could take, and when the eye is focusing on the screen, the amount of blink we get tends to reduce, so which will eventually lead to dry eye, and the dry eye, like she said, probably cause the keratitis the person end up having. So those are some of the steps you have to take, but at the same time, regular check, we always say, is the best way to manage, especially even if you're on the screen and you're having sometimes the symptoms may range from even headache or tearing, burning, sometimes foreign body sensation or in the eye. A lot of range of symptoms may come that may prompt you to go and check when you get those symptoms.
Let's add to the conversation the need to change eyewear, my glasses. I know we know that we work with individuals. The doctor says to me, come back in 2 years, but doc, I'm seeing well. Yeah, and then all of a sudden we start realizing headaches. I'm having these issues. Expound on that for me, Dr. Julian.
Okay, so the refraction changes as you grow older, for example, so there are changes in the eye. So, for example, a patient, let's use an example of a patient that is nearsighted or they have myopia. So the patient may be in the early teens, but as they age, there is consistent growth still of the ocular structure. It's still lengthening, the coverage of the cornea is still changing, and therefore the refraction changes. What does that mean? It means that the glasses that you have at the age of 7 is not the same prescription that you will then need at the age of 9, simply because the structure of the eye has changed or evolved, and therefore the correction needs to match what is the current reading. So if it is not matched, the patient will have a lot of headaches, eye pain, blurry vision, tearing when they're looking at the television or trying to use the screen time. So it's important to have it matched based on an age. So usually an average period of around 2 years is advised, and it changes, of course, according to the patient's need. There are some patients that they need even to switch glasses maybe at 1.5 years. It all depends on the individual and the underlying condition. If I have diabetic eye disease, my need may change more frequently. If I have glaucoma patients, they always tend to change the glasses more frequently. If a patient had surgery, so you had cataract surgery, and then 3 months later when the vision has stabilized, we advise you to change, even though you may have done the glasses prior, but then you have an artificial lens being inserted into the eye, which gives you a different refraction. So therefore that needs to be matched. So the need for the change of glasses is usually advised by your optometrist as well as the ophthalmologist. So in two, it's important to follow those regimes as it takes a lot of strain off the eye.
Dr. Franklin, I know time is lending itself away, but let's talk about some of the basic services that's offered by ClearVision that is available to the general public.
Okay, ClearVision, we offer comprehensive eye exam, and in comprehensive eye exam, as the patient comes in, we go through the first part where we call pre-screening, where the patient have to get the eye pressure check, have been subject to auto-refractor. There's a machine that will at least have access and assess your refractive error if you will need glasses, or if the what your refractive status look like. So that gives the doctor the impression of where you into. Then after that, we have visual acuity assessment. We also offer slit lamp examination. We have other equipment that we can use in refraction, whereby the doctor will subject to subjective refraction. At the end, we come up with if you need glasses. We also do internal examination. We have different machines. We have what we call visual field. Yes, we have visual field. We have OCT. OCT stands for optical coherence tomography. So these are machines that could go deeper in the back of the eye to assess and scan, whereby a doctor may suspect, okay, I've seen you, examine you. Sometimes we do dilation, and when the doctor suspects, okay, the nerve you may have early signs of glaucoma or some other pathology, he may recommend that you do scan, which is an extra exam that may require to pay extra money, and that will give the clear view of what the doctor is suspecting from the initial examination. We employ the service of ophthalmologist, Dr. Julian, sometimes consult with us, and we also have a referral pathway to both general practitioners, sometimes to medical general practitioners. And
well, let me ask you though, at the center, can we safely say it's a one-stop shop that you offer?
Yes.
Because most times customers do not like the hassle. I have to go by Dr. Martin, then Dr. Martin tells me, go by Dr. Julian across where, and then I can just visit ClearVision.
Right now, we have approached that stage whereby even if you have, because Dr. Julian there, and if you have a patient that have cataracts, we will just make an appointment, Dr. Julian will come to you in the office there on the days shift,
right,
and then see you, and then proceed to if you have to do surgery or other things.
They will make that evaluation. Dr. Julian, your final thoughts as we get ready to wrap?
So, Mr. Cadore, is very important, primary health care, as we were mentioning, but also preventative care, which is included. And of course, early diagnosis makes a world of difference in the visual outcome of the patient. So, I I emphasize the need to, I want everyone to have the best vision they can have, and therefore the best quality of life, because it is something that you watch a patient not being able to have any independence. They come in with reversible blindness, let's say from cataracts, they received a treatment, and then the patient is doing well after. So that patient can be reincorporated into society, can even start working back again, earning. So it makes a big difference in the life of the patient. So visual care is very, very important, and is something that we have to continuously work hard on. And as of present, we have an existing program which is going out there, bringing the expertise to the community. So we go to Guave Health Center, so we go to Sotez Health Center. There is Princess Alice Hospital, where they also receive clinics for vision care. In terms of St. George's, we know at the General Hospital, and of course we go to Carriacou every first Friday of the month, so that the patients that Carriacou, they can be seen up there and don't have to come. So coupled with the fact that in addition to these programs, you now have the outreach programs done by ClearVision, which for additional support of decentralization of services from the city. It makes a world of difference being able to go out there and capture cases earlier, and therefore to improve the health care and vision care of the nation.
Thank you, Dr. Julian. Dr. Martin?
I'm really happy to be able to speak after what Dr. Julian has just said, because you knew I intimated this earlier, that this is really what it is. This is really what a system should bring to its people. You should be able to catch them early, and what Dr. Julian has just described to me makes a world of a difference for me as well, in terms of understanding of what the people need, and certainly the plan that ClearVision has and the community outreach that ClearVision has speaks to the heart of primary healthcare, speaks to the heart of helping people. So I'm really happy about that. My last words are going to be this. Every one of us will have to visit the doctor at some stage in our lives. The question is, do you want to visit them when something is wrong, or do you want to visit them just to check? It's a philosophical thought. So there are well people's visit. In other words, you don't wait until they become sick, because doctors are well trained and they can predict when things are going to happen to you. So if you know you will have to see a doctor at some stage in your life, which stage would you rather see him at? You understand what I'm saying?
Well,
so it's a thought that everyone has to think about.
It's a thought that everyone has to think about. It's a question that's being asked. At which point would you prefer to see the doctor? When there's nothing that can be done, or where he can guide you? To all our listeners and all our viewers, that's the question of the day. But certainly we want to say thanks to our panel, Dr. Franklin, Dr. Julian, and Dr. Martin. To all of our friends from inside, from ClearVision, we want to say thank you for being part of this ongoing conversation of educating. It's not always possible that you can come to us today. We are opting to come to you. And again, reminding you that we have a lot of plans for you. Eye care is critical. It's critically important that you consider your eye care. Your eyes, the gateway to the world. You lose the gateway to the world, well, then you start seeing things differently. And when I say see differently, I really mean you see things differently. Again, reminding you, we are going to continue to come to you. How can you reach us? Our number is 440-0055, or you could contact us on 409-0055. For those of you, you're a little bit more techno-savvy, you can follow us online at ClearVisionGrenada.com, or you can email us clearvisiongnd@gmail.com. I did intimate to you that we have some outreach screening sessions that's scheduled. We start on the 17th of May, and we start in Grand Bras, then we move to Baltus on the 24th, and then to Birch Grove. The following month, June, we move to St. Patrick, then to Victoria. Later on in the month, St. David, and we make the trek back to St. George. But certainly as time progresses, I promise you that we'll continue to provide you. On behalf of the entire team, I'm Joseph Cadore saying thanks for being part of this conversation as we clear the air and give you a better vision on on life. Until then, so long, everybody. Keep seeing well and doing what you do better. Good.
Life is beautiful if only you can see it. Clear Vision Eye Center helps you do just that. We provide expert service, classy eyewear, and cutting-edge technology, all with a quality customer experience. See better, feel better, and look better. Meet us today at clearvisiongrenada.com or call 444-0055, WhatsApp 409-0055, or follow us on Facebook, Instagram,